Welcome to myiacademy.com. I'm Professor Mahfooz from Pakistan. In this video, VMCQ 10.1 will do the Glaucoma MCQs 1. So the first Glaucoma MCQ, a patient has an intraocular pressure of 27 mm of mercury with normal discs and normal nerve fiber analysis. Most likely diagnosis is. Now concentrate on the slide here. Optic disc is normal and nerve fiber analysis normal, so it is unlikely to be glaucoma. So one of the option now is open angle glaucoma, unlikely. Closed angle glaucoma, unlikely because there is no glaucomatous damage. Normal tension glaucoma, again unlikely because there is no glaucomatous damage. Ocular hypertension, that may be the answer because in ocular hypertension there is no damage. And the fifth option is secondary glaucoma. Again, secondary glaucoma is a glaucoma and does cause nerve fiber damage. So the answer is probably ocular hypertension. For that you have to remember few things in chapters 10.2, and these are the definitions. Glaucoma, optic neuropathy in which there is a disc damage and nerve fiber damage. Then normal tension glaucoma, IOP is normal but there is damage. Ocular hypertension, pressure is more than 21 mm of mercury and no glaucomatous damage. So the answer would be ocular hypertension. Let's see. Yes, the answer is ocular hypertension. Next MCQ. A patient has intraocular pressure of 16 mm of mercury, has 0.9 cup disc ratio and visual field defects. Most likely diagnosis is closed angle glaucoma, open angle glaucoma, normal tension glaucoma, ocular hypertension or secondary glaucoma. Here the pressure is 16, so the pressure is not high. For closed angle, open angle and secondary glaucoma, one of the criteria for diagnosing is increased intraocular pressure. So these three are out. In ocular hypertension there is no damage, but here there is a cup disc ratio and field defects. So the only option we are left with is the normal tension glaucoma. That may be the answer. Normal tension glaucoma is the answer. Next MCQ. A patient has got intraocular pressure of 26 mm of mercury with CD ratio of 0.3, which is normal, and no detected damage on the OCT. Now, intraocular pressure is 26, disc is normal, and no damage on the OCT. So the most likely diagnosis is open angle glaucoma, closed angle glaucoma, normal tension glaucoma, ocular hypertension, or secondary glaucoma. Now concentrate here. The pressure is 26 but everything else is normal, so it's perhaps not a glaucoma, so it would be ocular hypertension again. Let's see the answer. Ocular hypertension is the answer. Next MCQ. A patient has intraocular pressure of 18 mm of mercury with cup disc ratio of 0.7 and nerve damage on the OCT. Now concentrate on the stem. There is damage to the disc and damage on the OCT, so it is a glaucoma, but the pressure is within the normal limits. So it cannot be closed angle because the pressure is high in the closed angle. It cannot be open angle because the pressure is high. Ocular hypertension, the pressure is high. Secondary glaucoma, the pressure is high. So this could be normal tension glaucoma again. Let's see the answer. Normal tension glaucoma is the answer. Next MCQ. A patient diagnosed with glaucoma has an open anterior chamber angle and pigment dispersion in the anterior chamber. Most likely diagnosis is primary open angle glaucoma, normal tension glaucoma, neovascular glaucoma, ocular hypertension, or secondary open-angle glaucoma. The first option is primary open-angle glaucoma. It's not possible because there is a reason for the glaucoma, which is pigment. Normal tension glaucoma, the tension is normal. Neovascular glaucoma is the new vessels in the eye which are not mentioned in the stem. Ocular hypertension, there's no pigment dispersion in the ocular hypertension, so secondary open-angle glaucoma could be the answer. Remember from the glaucoma slides, open-angle glaucoma is primary open-angle glaucoma in which there is no known cause, or secondary open-angle glaucoma in which the causes is pigment dispersion, pseudoexfoliation, inflammatory exudate, or blood cells. So if you remember this slide, you will be able to answer the question, which in this case is secondary open-angle glaucoma. Secondary open-angle glaucoma is the answer. Next question. A patient diagnosed with the glaucoma has open anterior chamber angle and white flecks on the pupil margin and lens. Whenever the white flecks on the pupil margin and lens come in the stem, that will point out towards the pseudoexfoliation, and you can see that in the glaucoma lectures. So the options are normal tension glaucoma, neovascular glaucoma, ocular hypertension, primary open-angle glaucoma, or secondary open-angle glaucoma. Pseudoexfoliation is a type of secondary open-angle glaucoma, so that would be the answer. Number 5 is the answer. Yes, secondary open-angle glaucoma is the answer. Next question. A patient diagnosed with glaucoma has open anterior chamber and white flecks on the pupil margin and lens. Remember, the white flecks means pseudoexfoliation or secondary open-angle glaucoma, so one of the options would be there. Lens-induced glaucoma, no. Neovascular glaucoma, no. Primary open-angle glaucoma, no. Pigment dispersion, no, because they're white flecks. Pseudoexfoliation glaucoma would be the answer because they're white flecks. So the stem may be with the pseudoexfoliation glaucoma or with secondary open-angle glaucoma. Both will be right. Pseudoexfoliation glaucoma is the answer. A patient diagnosed with a glaucoma has open anterior chamber angle and pigment on the corneal endothelium and lens surface. When the pigment comes on the lens or endothelial surface, the answer would be pigment dispersion or secondary open angle. So look for the options. Lens-induced glaucoma, no. Neovascular glaucoma, no. Primary open-angle glaucoma, no. Pigment dispersion glaucoma, yes. Pseudoexfoliation, no. So the answer would be pigment dispersion. And pigment dispersion glaucoma is the answer. Next MCQ. A patient diagnosed with a cataract for 10 years. Now he came to the clinic with a very high pressure in the eye. Cornea is hazy with no visible details of the anterior chamber, most likely diagnosis. When the cataract is for that much long time, then the cataract can cause secondary glaucoma, and we call it lens-induced glaucoma. So the options are lens-induced glaucoma, primary open-angle glaucoma, no. Pigment dispersion, there's no mention of pigment in the stem. Neovascular glaucoma, no mention of new vessels in the stem. Pseudoexfoliation glaucoma, no mention of the white flecks in the stem. So the answer would be lens-induced glaucoma. And lens-induced glaucoma is the answer. Next MCQ. A patient had central retinal artery occlusion 3 months ago. He has come to the clinic with pain in the eye and high intraocular pressure on the examination. Most likely diagnosis is when the artery closes, the body forms the new vessels, and those new vessels then cause glaucoma. So that's how you guess that it could be a neovascular glaucoma. The options are lens-induced glaucoma, neovascular, primary open, primary angle closure, or pseudoexfoliation. As I already said, the answer could be neovascular glaucoma because the retinal artery occlusion makes new blood vessels. Neovascular glaucoma is the answer. Glaucoma is classified into open angle and closed angle on the basis of. It's a very basic answer and very basic thing to understand. So the options are angle of anterior chamber, capacity of anterior chamber, cup disc ratio, depth of anterior chamber, or intraocular pressure. The glaucoma is differentiated into open and closed angle on the basis of angle of the anterior chamber. If the angle of the anterior chamber is open, we call it open angle. If the angle of the anterior chamber is closed, we call it closed angle. So the answer is number 1. Angle of the anterior chamber is the answer. A patient has an IOP of 26 mm of mercury, high CD ratio, nerve fiber damage, and open anterior chamber angle. Most common reason for the IOP is. Now here the question is about the reason of the pathophysiology. So pathophysiology of what? High intraocular pressure, high CD ratio, nerve fiber damage. So it is a open angle glaucoma because there is no mention of white flecks or pigment or new vessels. So this means it's a primary open angle glaucoma. In other words, the question is being asked, what is the pathophysiology of primary open angle glaucoma? The options are increase aqueous production, reduce uvascular drainage, resistance in the trabecular meshwork, dilation of the trabecular meshwork spaces, or damage to the ciliary body. Remember, almost always the reason or the pathophysiology behind the primary open glaucoma is resistance in the trabecular meshwork, which causes the pressure to rise. So the answer would be number 3, resistance in the trabecular meshwork. Thank you very much for being with me. Thank you.